Assalamu alaikum and good morning. Today we will be starting with the endocrine disorders. In previous six lectures, we have been covering diabetes mellitus, and diabetes mellitus primarily, though an endocrine disorder by virtue of this insulin and all that, but we have discussed that diabetes is a separate entity in itself. It is not just an endocrine disorder. It manifests as hyperglycemia and but has effects on vascular system and so many other body organs, so that it has been dealt with separately. Today we will be starting with the endocrine disorders, and first in few first slides will be talking about the general organization of the endocrine system and various endocrine glands, and then we'll be talking about starting today with the pituitary disorders. This is one of my favorite say pictures. It was taken some 5-6 years ago in Blue Mountains, Australia. What you see on this picture is that there are multiple trees, but they look like one single say entity. There are roots or their trunks. You might saw the trunk of each individual tree, which then unites, and then each one stands out independently of that. Now assume that this is your pituitary gland, and these soil is function as its hypothalamus. Now hypothalamus has its say certain stems moving into the pituitary gland, which we called as the releasing hormones, and from pituitary then individually each one of the hormone is further produced and it stands out as independently. You may call them this as a thyroid stimulating hormone, adrenocorticotropic hormone, FH, LH, growth hormone, or maybe oxytocin, and from there are the releasing hormone. But this is just to make you familiarize with that how the functions or endocrine system functions. This is what you have been familiar with, and you probably have been studying this since your second year of MBBS, that you have a master gland in the form of what we call as pituitary gland, and in this master itself is under effect of the hypothalamus. So this hypothalamus and this pituitary gland then secretes certain hormones, which then have their effect on the thyroid gland, maybe on the thymus itself is a separate entity. Then there is a pancreas, which is, as we have already discussed, with insulin and glucagon and diabetes control. Then there are adrenal, which are also called suprarenal glands, which release cortisol and related hormones. And then gonads in male and ovaries in female, they are also the organs which produce hormones under the effect of hormone released from the first from the hypothalamus, then from the pituitary. Now these organs, these are called target glands, right? And the main master gland is pituitary gland. How does it function? First we may talk about what endocrine disorders are. The endocrine disorders are disease states which result from either an excess or insufficiency of a hormone. And definition of a hormone is that it is produced by a gland, and secretions are say poured into the blood circulation, and the blood circulation then takes it to various body parts or organs where this hormone has its effect in either increasing the function of that gland, or maybe decreasing or reducing the function of that gland. Whenever there is an endocrine disorder, which as you said would be either an excess production of a hormone or a deficient or insufficient production of hormone, it would have that what is the clinical effect of that deficiency or excess, and of course why this excess occurred, which was the say organ at fault which resulted in the increased production or the decreased production and sometimes decreased effect of that very hormone. The target glands can be at fault. So when it is so, we call them a primary endocrine dysfunction. The pituitary can be at fault. So when the pituitary excrete less or more of a hormone acting on a target gland, it would be called as a secondary. And if it is hypothalamus, which is excreting more or less of a hormone, which then results in an overfunction by the pituitary and then finally overfunction or malfunction by the target gland, then it is called as a tertiary effect or tertiary cause of that hormone excess or decrease. The endocrine disorders can stem from the dysfunction of thyroid, of adrenal, of parathyroid gland, pituitary gland, gonads, and sometimes this uric acid now is also being considered as that it has some effect like hormone. Similarly, sometimes vitamin D is also to be considered as it because of its function on various target organs. Sometimes some people do regard it as say sort of some kind of a endocrine type of a function, but since it is not excreted by any gland, same is the case with the uric acid, they are not conventionally called as endocrine disorders. You must concentrate on this diagram. I will try to explain this diagram in more detail so that you have an idea that what we will be looking for. So you have hypothalamus over here, and this hypothalamus produces certain releasing hormones. They will end up in RH, right? And there are some of them which are probably do not have that suffix, and they are called something. But this hypothalamus, when it's produced hormones, they act onto the pituitary gland. This is the pituitary gland's various say cells which produce certain hormone in response to stimulation or inhibition by the hypothalamus. So we start from that the first hormone which is produced by the arginine vasopressin, and it has its effect on primarily the effect is on the to produce a positive feedback effect on the ACTH. Similarly, there's the other hormone released by the hypothalamus is corticotrophin releasing hormone, and again, of course, it cortisol producing say effect onto the adrenals, but from the pituitary, the hormone that is released is ACTH. So it is a stimulatory or positive effect for this. Then there is gonadotrophin releasing hormone, which again on the pituitary leads on to release of luteinizing hormone, and it also leads on to releasing of follicle stimulating hormone. Then there is growth hormone releasing hormone, again having a positive effect on the growth hormone released by the pituitary. And then there is somatostatin release inhibiting factor. You have a positive effect on from by the hypothalamus, and there is similarly a negative effect as well, that this growth has to be checked, and this is somatostatin release inhibiting factor, which again has a negative effect on growth hormone. So release of this hormone by the hypothalamus would lead on to decrease in release or production of the growth hormone. But at the same time, this growth hormone, this somatostatin release inhibitory factor has a negative effect on the TSH, so that it inhibits the TSH, so it would lead on to lesser of TSH production and lesser stimulation of the this thyroid gland. Thyroid gland, then hypothalamus produce a thyrotrophin releasing hormone, which on one side has a positive effect on thyroid stimulating hormone, and on the same side it has a positive effect on the prolactin releasing area or cell and right. Then there is vasoactive intestinal polypeptides released from elsewhere, and they also have a positive effect on prolactin. And finally, the hypothalamus is a seat of production of dopamine, and this dopamine has a negative effect on prolactin. So if you look at this diagram, the hypothalamus in majority of the cases is responsible for positive or stimulatory effect onto the pituitary cells of various releasing hormones, but it also have a negative effect on this. It also has a negative effect on thyroid, and similarly dopamine has a negative effect on. That's why that any dopamine excess would lead on to decrease in prolactin production, right? And similarly, if there are intrinsically prolactin is produced in excess, you may use dopamine agonist as an inhibitory effect. Similarly, someone who has increased thyrotrophin releasing hormone would have, on one end, it would have a more increased TSH, and on the other hand, it would lead on to more of a prolactin. Now, again, this increased prolactin and increased TSH. So, sometimes this central this increased TSH may have a simultaneous prolactin inhibition as well. Then it is customary to divide this pituitary gland into anterior pituitary and posterior pituitary. The main hormones produced by the anterior pituitary is the one which we have listed over here, but the posterior pituitary primarily is responsible for only two hormones, which is we go on to this hormone. Now this again is anatomy, that you have pituitary gland comprising of anterior portion, which is actually a gland, and a posterior portion which is actually an extension of the nervous tissue from the hypothalamus. These two are fused together, but they function independent of each other. As far as this anterior pituitary is concerned, and which is the hormone which we described as thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, growth hormone, and prolactin, they are all produced by the anterior pituitary under the effect of this hypothalamus secretions, which are transported to it through blood. So there is a superior hypophyseal artery which produces, takes on the stimulatory hormone or inhibitory hormone from the hypothalamus and then to the pituitary. Pituitary secretes its secretions and then pours into this through portal circulation into the bloodstream. But when you go on to the posterior pituitary, that is something unique, that you have these first order neurons in the hypothalamus, and they have their extension axons which end up directly into the posterior pituitary as the nerve endings, and it is these nerves which release certain hormones which are then taken up by the circulation from the posterior, and then they are taken on into the circulation. Now this posterior pituitary generally is considered as an extension of neuronal connections from the hypothalamus, whereas the anterior pituitary is an endocrine gland in itself, but both of them, they pour their secretions into the circulation. The posterior pituitary circulation secretions are ADH, antidiuretic hormone, and oxytocin, whereas the anterior pituitary hormone we already listed previously. The pituitary disorders can take on the form of an increase in size in the form of adenomas or tumors. Sometimes this pituitary can lead on to this adenomas. In most of the cases would be responsible for an increased production of a certain hormones or say stimulatory hormones from the pituitary, depending upon which cells are affected. Then this pituitary can undergo, say, necrosis, can be affected by autoimmune disorders, can be affected by glandular disorder, leading on to decrease in function or production of hormones from the anterior pituitary, and this would lead on to hypopituitarism. Sometimes this pituitary can undergo an acute necrosis as a result of severe hemorrhage into that pituitary gland, or an acute necrosis or in sepsis and so on. And this acute loss of hormone production by the pituitary is called as pituitary apoplexy. And then the pituitary adenomas can be a separate entity, that they are just adenomas involving the pituitary, and sometimes they may be part of endocrine neoplasias elsewhere as well. So this is called as multiple endocrine neoplasia, meaning by they would have involvement of the pituitary, of the pancreas, of sometimes pheochromocytoma, adrenal associated with, and these disorders can be inherited as autosomal dominant, and there may be families having these disorders in other family members as well, and this is called as multiple endocrine neoplasia. And in coming lectures we will be talking about this, both the endocrine neoplasias and of course the endocrine dysfunction as a result of loss of function. How can we check that pituitary function is okay, or a certain hormone deficiency is not as a result of a pituitary gland dynamics being disturbed? So whenever you have a gland, endocrine gland, particularly in this case we are talking about pituitary, it is hyperfunctioning. So the hyperfunctioning gland, say, escapes the feedback control, and it cannot be suppressed by increased amount of hormone. So whenever there is an excess of production of a certain hormone, a further stimulation, this suppression of this gland by use of certain inhibitory factors is not possible, because this gland becomes autonomous and has lost its control by the negative feedback mechanisms. Same is true for a hypofunctioning gland. So when gland is not producing adequate secretions or it's hypofunctioning, so we try to stimulate it by the stimulatory hormone for that very component, and it cannot be stimulated. So if you remember these two, say, sort of a golden words, a hyperfunctioning gland cannot be suppressed, and a hypofunctioning gland cannot be stimulated because it has lost its secretions to be produced as a result of stimulation. So whenever we are going for the further endocrine test to prove that the gland is either hyperfunctioning or hyperfunctioning, we use this stimulatory or suppression test to look whether this gland is able to be stimulated or not. Now, these are the various, say, effect which can lead on to stimulation or can tell us the assessment of very, like giving someone insulin would produce hypoglycemia, right? And hypoglycemia, low sugar level, is a signal for the pituitary to produce more growth hormone and more acetylcorticotrophin hormone to compensate for hyperglycemia, right? So whenever you induce hypoglycemia, you expect the growth hormone or ACTH level to increase as a result of hypoglycemia. So if the gland has the reserves and can produce more, then it will respond to. But if it has lost its function to produce growth hormone, the insulin induced hypoglycemia will not lead on to an increase in level of growth hormone or ACTH. Glucagon does the opposite. Glucagon would lead on to hyperglycemia. and whenever there is an increased amount of glucose, it gives a negative effect onto the pituitary, and it should lead on to decrease in growth hormone and ACTH. Now, if the gland is under the influence of this feedback mechanism, it would lead on to decrease in growth hormone and ACTH when glucagon is administered. But as we said, that once this gland has developed an adenoma or any other excess producing tumor producing area, this is not under control of feedback, and it would not result in suppression of growth hormone or ACTH as a result of glucagon induced hyperglycemia. Same way, we can use the glucose tolerance test for the assessment of the growth hormone or ACTH. We can use ACTH stimulation test. Now, ACTH, since it leads on to stimulation of the adrenal function, so whenever hypofunctioning adrenal, if it is has some reserve to release cortisol, under effect ACTH would lead on to an increase in cortisol level. But in the other case, if it is totally destroyed, it would not lead on to any stimulation. Arginine again is, as we mentioned, is say lead on to growth hormone release. So if you give arginine, and if we want to check that growth hormone reserve is there, this is a second line test for growth hormone excess. Clomiphene, since it inhibits the hypothalamic estrogen binding, so this would lead on to increase in LH and FSH after 3 days, and this is when we assess the gonadotrophin function of the pituitary. Gonadotrophin releasing hormone test would also assess for the luteinizing hormone or FSH, and thyroid releasing hormone, of course, would check the functional state of the pituitary to be able to produce TSH in response to TRH test. Right. Now, this is with this background, we now start with the study of the pituitary malfunction or dysfunction in various conditions or disorders. This is one of a picture from an old textbook of medicine, where, as you can see, some of the people are looking at a very sort of a huge kind of a person who is very tall and very say has gained height which is much more than the normal individual's heights. We start with as we usually do, in form of a case scenario. So this is our first case in relation to this pituitary disorders, and we'll be going on for about 7 or 8 such cases in coming days. A 50-year-old male has presented in outpatient department with complaints of off and on headache, poor concentration and fatigue. He has gained weight. He also noticed that he has a lot of sweating, that his palms are almost always wet. He also noticed that when he is trying to take a bite and his say bolus is churned in his teeth, the food particles get stuck into his teeth spaces, which are unusually white. His skin has coarsened over the years, and he has developed multiple skin tags. His friends also report that he has a heavy and doughy and sweaty handshake. And another thing they had noticed, that he does not notice people sitting on either sides of his desk. So when he is on his desk, he would be well attentive to the person sitting in front, but he may not have take notice of that there is someone sitting on his right or left or on both of his temporal sides. Now this, if you focus on that, this peculiar symptom of what we call a bitemporal hemianopia, not being able to see in the temporal half of your fields, would be as a result of something which is pressing onto the optic chiasma. And if you remember, the optic chiasma is where the crossing of the medial fiber of the optic nerve from both sides cross over to the opposite side. So that's why this represents the medial portion represents the temporal field of vision. So any defect of that. Now this one single say component of his history gives us that we are talking of something which is pressing on to the optic chiasma, and the structure which is say immediately adjacent to that or slightly above that is the pituitary gland, and it's dark. So this leads us to think that whatever this person is having, possibly having some anatomical location in the region of the pituitary gland, which might have grown bigger in size and has started pressing onto the adjacent structure, particularly the optic chiasma. And this optic chiasma has resulted in bitemporal hemianopia. And then there are the features which probably suggest some excess of certain hormones being produced because of this pituitary enlargement and growth. So there are few effects which are mechanical as a result of enlarged pituitary gland, and there are few effects which are because of the extra, and sometimes not only extra, sometimes defective production of certain hormones from the pituitary gland. Now this gentleman has a blood pressure of 160 over 100, and he has displaced cardiac apex in 6 intercostal space, suggesting that he has developed cardiomegaly. There is also other organs being enlarged, like hepatosplenomegaly is noticed on abdominal examination. And then he had no previous history of diabetes, but his blood sugar random turned out to be 240 milligram, suggesting that he probably has also developed diabetes. Again, maybe diabetes from the pancreatic region, and maybe an excess production of certain factors which can lead on to increased production of glucose, which is not matched with matching release of insulin. And of course he has glycosuria as well. This is a picture to show this person's jaw and teeth, and which shows, as we mentioned, that there is a lot of space in between the teeth, which suggests that his bone has expanded, leading on to the teeth widening. And this is again his broadened hands, which again is as a result of a soft tissue hypertrophy, and these hands are called spade-like hands. I hope that with this so much of explanation by us, you can make out that this person has what? It's acromegaly. What it is? Now, acromegaly is results from metabolic tissue and organ responses to excess of growth hormone in the adults. Now, if you have an increased growth hormone in very young people, they would grow linearly. Linearly mean in their height, and they would become, each and every organ of them would become say enlarged. So this is what we call giantism. But when it happens at a later age, when the bone cannot go linearly, this epiphyses have say, closed and completed, then there is no linear growth, then it is growth in the transverse growth or breadth, and this would lead on to, which is widening of the wrist, widening of the bone, widening of the joints. The growth hormone is a polypeptide. It is a single chain polypeptide which comprises of some 191 amino acids. It is produced by the somatotrophic cells of the anterior pituitary gland, and you have to remember this value. The fasting serum value of this growth hormone is around less than 5 nanogram per ml. So you have to check in the fasting state. We did talk about that the both say hypoglycemia as well as hyperglycemia or fasting state or a post meal state does have effect on the release of this growth hormone, and so it's better check in the fasting state. We'll talk about the effect of this hormone from one by one. On top of this, we have this hypothalamus, right? And then we have this anterior pituitary gland, and this anterior pituitary gland is, as you said, under the effect of somatostatin releasing hormone and under the effect of growth hormone releasing hormone. Now, this is say results in say positive effect, and this results in a negative effect or inhibitory effect on it. And from the anterior pituitary, you have a release of growth hormone. Growth hormone, of course, its level would have a negative effect onto the hypothalamus pituitary, so that secretion is decreased, and it may have a positive effect onto this release of somatostatin. Right. So the following factors act at the level of the hypothalamus, like from the growth hormone releasing hormone, ghrelin, which is actually released from the stomach, certain sex hormones, sleep, fasting, exercise, arginine, they all have a positive effect onto this hypothalamus as well as onto this anterior pituitary, and would lead on to stimulation of this pituitary. On the other hand, insulin-like growth factor, steroids, hyperglycemia, somatostatin, they would have a negative effect on growth hormone releasing hormone. Now, this growth hormone then has its effect onto the liver, and from the liver it produces insulin-like growth factor 1, IGF-1, and this has its effect on bone to increase in their linear, say, growth, cartilage, and other tissues, and it also has its effect onto the back onto the negative effect onto the pituitary. Growth hormone also has as its target glands the hepatocytes, adipocyte, heart muscle, diaphragm, all these lead to an increased growth. The growth hormone has from here has metabolic effect, that it has an anti-insulin, would lead on to increased glucose, anabolic would lead on to more tissue being used, and it would also has its effect onto the, so this then results into raised this IGF would result in impaired insulin sensitivity, would cause hyperglycemia, and sometimes it also lead on to break down the pancreas. Now, this is the whole say mechanism of action of growth hormones on the pituitary, right? How it is inhibited, how it is stimulated, how it has its effect not directly but through release of IGF-1 from the liver, right? Now, as we know, this growth hormone level is variable. It affects by sleep, by fasting, by exercise, by so many other things. It is affected by glucose level. So measuring growth hormone level static may not be as effective a tool of investigating, but measuring IGF, which is not affected by all these things, would be more appropriate measure for assess the activity of growth hormone. Whenever growth hormone is deficient or is produced less, this can be as a result of either congenital abnormalities of the pituitary. It can be as a result of intracranial tumors which suppress the growth hormone producing cells like craniopharyngiomas. It can result from surgery or trauma or radiation to pituitary area, and more commonly maybe hemorrhage into that area, this classical example of Sheehan syndrome. And sometimes this growth hormone deficiency can be autoimmune. On the other hand, the growth hormone excess is as a result of either micro or macro adenomas. Microadenomas, we call the tumor is less than 1 centimeter in size, and if it is more than 1 centimeter, this is called as a macroadenoma. And we did discuss just a short while ago that multiple endocrine neoplasia, this growth hormone excess, can be part of a pituitary tumor, which is in fact further a component of a endocrine neoplasias elsewhere in the other organs like pancreas, pituitary, parathyroid, or so many other. We'll be talking. And sometimes this can be as a result of a growth hormone releasing hormone from the hypothalamus. And this not only hypothalamus, this growth hormone releasing hormone can originate from, say, ectopic tissues in other than hypothalamic-pituitary, from various, say, other as a manifestation, paraneoplastic manifestation of certain tumors. So we talked about two terms. One was acromegaly and the other was gigantism. Now, acromegaly is a condition in adults caused by hypersecretion growth hormone after the closure of the epiphyseal plates, and this would lead on to broadening of the bones and tissues and hypertrophy. On the other hand, gigantism occurs if the growth hormone excess starts in children or adolescents before their physical closure, and this would lead on to a very tall and lanky and the increase in height of the individuals. Something about the genetics, the gigantism, which is usually inherited and manifested during childhood or adolescence, results from a gene, say, on the X chromosome, and this gene is named as growth producing 101 or GPR 101, and this gene on X chromosome is overexpressed, right? And this overexpression would lead on to more production of growth hormone from the very early childhood. Sometimes this gene can result as a result of mutation which is responsible for almost 4% of the cases in the acromegaly. And this GRP101 gene may be target for the treatment of growth disorders that we might have soon this GPR101 gene being manipulated by genetic engineering to either being expressed or not expressed in X chromosomes, so we can possibly treat these individuals by say, genetic engineering as well. In acromegaly, the signs and symptoms primarily stem from the growth hormone excess. As you said, some of its mechanical effect would be as a result of this, since majority of these are as a result of a pituitary adenoma. This pituitary adenoma, as we said, can lead on to compression effect onto the this optic chiasma, and the first symptoms may be this visual field defects, right? So there is hypertrophy of the skull tissues, which leads on to prominent supraorbital ridges. This is say large protrusion of the jaw, which is called as prognathism. They're large, the nose and jaw, they also get hypertrophied. It has effect onto this increased, say, anti-insulin effect, for which would lead on to this patient may developing hyperglycemia and maybe frank diabetes. Their hands become broader, and this shape becomes spade shaped. There is an increased height and weight and everything, and this then maybe leads on to effect on the joints, leading on to osteoarthrosis. Their peripheral nerves may become hypertrophy and may show dysfunction. There would be sexual dysfunction. The organomegaly can result in development of cardiomegaly and development of hypertension. Since we did talk about that this gonadotropin releasing hormone have a positive or stimulatory effect on the prolactin, so sometimes they may also show galactorrhea. And then there is this the sebaceous gland, sweat gland are also under this effect. So there is increased production of sebum or oily secretions and increased production of sweat. So there, the handshake is almost always wet and very, say, doughy type of feeling. The complications which results as a result of this acromegaly, that on one hand there is an increased say production of a hormone from the growth hormone producing cells, but this suppresses the other hormone producing cells in the pituitary, so the other secretions may be suppressed. So on one hand, there may be an increased production of growth hormone, but simultaneously there may be either suppression of TSH as a result of this being compressed, or suppression of FSH, or there may be other features of hypopituitarism associated with that. Sometimes this gland may, the tumor may develop necrosis as a result of increased growth, and then may present as clinical features of acute hypopituitarism. Visual defects we just talked about. Hypertension, we again talked about that there is an hypertrophy of the heart and acromegaly and increased vesicle tone. They may develop frank diabetes. Cardiomegaly can finally end up in cardiac failure and symptoms of heart failure. The compression of the nerves as a result of hypertrophy of the soft tissues, particularly at the wrist, may lead on to carpal tunnel syndrome or pain in the median nerve distribution. Increased bone growth and increased tissues may compress the cord, and they may sometimes present the cord compression signs. They are likely to develop not only the skin tag hypertrophy, but they develop colon polyps, and sometimes may present with symptoms like production as a result of bleeding PR or bleeding per rectum. Now, when you want to check that, assess the function, we did talk about that it looks it's very easy to say that serum growth hormone estimation would be, say, diagnostic test. But as we did talk about that this serum growth hormone level is affected by so many things that at times you may not have a static level for that. It is affected by sleep, it is affected by hunger, it is affected by whether they are fed or not fed, what is blood glucose level. So estimating the serum growth hormone alone may not be very reliable. But we did talk about that this growth hormone, say, then effect onto the liver, and from the liver there is a production of a insulin-like growth factor 1 or IGF-1, and there is also IGF binding protein 3 which is produced. So if you estimate this IGF level 1 in a static condition without any stimulated test, you can possibly have more say accurate estimation of growth hormone function. Sometimes these patients may develop some hypercalcemia and hyperphosphatemia as well. They may have, not always, but they may have decreased TSH and secondarily then decreased T4 as well if the growth hormone producing, say, adenoma is pressing onto the TSH producing cells. We did talk about hyperprolactinemia. We did test that the mammoth somatotrophs are the most common type of growth hormone secreting cells, and this could lead on to again childhood gigantism as well. And then we talk about that they would have hyperglycemia as well. But the most reliable test would be, as we said, when you have deficiency of a hormone, you try to stimulate it, and when you have an overactive gland, you try to suppress it. What suppresses the growth hormone secretion is glucose. So if you give someone 75 gram of glucose orally and check his growth hormone levels at around 60 minutes, 20 minutes, and 120 minutes after the administration of glucose, if this secretion of growth hormone level is reduced to less than 1 nanogram per ml, it is excluded, because as we said, an gland should not be suppressed as a result of suppressing agents, because it becomes autonomous. This is just say the representation of what happened and what do you expect, right? Okay. So in this diagram, you look at this. This is the normal individual's blood glucose level, and this is normal patient with acromegaly, and is this growth hormone level. So this is the growth hormone level, and on this side, this is the blood glucose level, right? So if you give the start from here, and a normal individual, you give 75 this gram glucose. After some time, this would lead on to say an increase in the a normal individual would have an increase say blood glucose level, right? And along with that, this would lead on to around 60 minutes to 90 minutes, the blood glucose level go down, right? And what would happen to this say this level of growth hormone? It would go matching along with this, right? But in acromegaly patients, you would have the normal individual would have with this rising glucose level, there would be a decrease in the growth hormone level, right? So on this side, there will be growth hormone level. So this is the response that elevation in glucose would lead on to suppression of this risk. But what happens in acromegaly, that your glucose is elevated, right? But there is no corresponding decrease in the level of growth hormone. Growth hormone remains as such and does not get suppressed to level below that. Then there are imaging studies, right? As we said, this generally is broadening of the bones, and this would lead on to the tuft-like distal fingers and broadening of this metacarpal and phalangeal bones. If you go for a say skull X-ray, this would lead on to this widening of this pituitary fossa on a lateral skull X-ray, and if you go on to the MRI, then you can possibly see this huge tumor occupying this pituitary area. This is a pituitary adenoma. Other tests you can perform is an ECG. You can go for echocardiography for looking for the LVH or acromegaly. Sometime for polyps, and the one who is presented with bleeding PR, you might have to go for a colonoscopy, but that would be depending upon the patient's symptoms. Right? How do you treat it? The first line treatment for acromegaly resulting from pituitary macroadenoma would be pituitary microsurgery. The second line of treatment would be going for radiosurgery or a gamma knife surgery. Gamma knife surgery is just using a say targeted say radium say frequency beam onto that tissue with very through the stereotactic techniques, and this would result in this say gland being say suppressed. In second line, we also have medical therapies, and we can use somatostatin analogs, and we can use dopamine agonist, and we can use growth hormone receptor antagonist, and the microsurgery can be performed through this transsphenoidal approach, hypophysectomy, and that is a dual advantage that it can also improve the symptoms as a result of mass effect, which may be causing this optic chiasma, say compression, and leading on to this bitemporal hemianopia, and it would not only reduce the production of growth hormone, but it would also lead on to reducing the size of the tumor. Radiotherapy, as I said, extended therapy is either used alone or in combination after surgery. So you go for initial reduction in size of the tumor by the surgical approach, and if any remnant tissues are left, they are then with the radiotherapy, and sometimes you can use radiotherapy as a separate or individual entity without having need to operate these patients. There is risk involved is that this radiotherapy may lead on to total suppression of the gland, whole of the gland, and you may lead on finally the pan-hypopituitarism. The medical therapies, as they are second-line therapy after surgery to reduce the growth hormone levels to less than 5 microunits per liter. You can use dopamine agonist. We did show in the beginning that the dopamine agonist like bromkriptine, they have a negative effect onto the release of this hormone. So they would not affect the size of the tumor, but they would lead on to decrease in the release of growth hormone. Bromkriptine is more commonly available. It can be used in the dose of 2.5 to 10 milligram per day, depending upon the tolerance or acceptance by the patients or the side effects. Cabergoline is more specific, and it not only has effect on the growth hormone, but as well as on the prolactin secreting, right? You can use somatostatin analogs. We did show that the somatostatin, by the word statin, mean that somatic tissue they lead on to say suppression, and the octreotide and lenalidomide subcutaneous injections can be used as an alternative to say surgical option or those who are not fit for surgery. Then there is another drug by the name of growth hormone receptor antagonist, where this pegolisomant. It is usually primarily for the symptomatic relief only. It would have its effect on the receptors on which the growth hormone acts. It would not have any effect onto the tumor size or anything. So in inoperable cases or in some patients which are not fit for surgery, only this receptor antagonist may be of help. Once you have treated these patients, you check for whether they have responded to these. You follow them up. Cure or adequate control of growth hormone excess is defined as that after you have operated them, glucose suppressed growth hormone concentration of less than 2 nanogram per ml. This can be done through the radioimmunoassay or normalization of serum insulin like growth factor IGF-1 concentration. So once you have operated these patients, you check for these levels, and if this IGF has reduced to normal or growth hormone level after glucose say suppression is less than 2 nanogram, it suggests that the patient is has cured. So in summary, acromegaly is a rare and insidious and potentially life-threatening condition. Life-threatening when there is this leads on to tumor getting a bleed into it, and the patient may develop an acute pituitary apoplexy. But it can be very responsive to treatment, although it may be incomplete, and treatment can add at least a number of years to the quality of the patient's life, and as well as may increase the life expectancy. That increased and unregulated growth hormone production, usually caused by growth hormone secreting with tumors, characterizes the acromegaly. Now, this is one of the picture which you have to see and probably give us that what is the diagnosis, what is the best test to diagnose this condition, and you have to list 3 further investigation to confirm the diagnosis. Now that ends our today's presentation, and will be in next coming lecture we'll be talking about the pituitary function in the form of say decreased function and all that. So thank you very much for your say patient listening, and thank you.